Good morning, everybody. Good afternoon to those from far away. It's once again a pleasure to have you back at our Monty Hardcat conference and to welcome back Professor Ashok Seth. Professor Seth is really a great friend, most importantly, but also he's really truly a worldwide expert in both coronary and structural intervention. So it's been really kind of him to dedicate. He's given us, this is the second lecture he's given us. And Ashok, I know how busy you are. And so thank you so much for taking time out of your busy schedule to spend some time with us here in New York.
Thank you very much. Thank you, Azim. What a pleasure to be with you, and what a pleasure to be with all the fellows and the young interventional cardiologists for today's session. I would wish I could see you guys in person, but truly, I love to take this time out for this great session that you have every Tuesday. It's in fact a privilege to be at the session. It's ranked, by the way, Azim, it's about the top 2 sessions of the world, which a lot of young learners attend. And so I congratulate you for this program. So today we're going to discuss this very interesting topic of anomalous coronary arteries, tips and tricks. And I don't think it would have been covered. And if it has, well, you'll just get a different flavor of it. Because these are rare, challenging, time-consuming cases for all of us, even the most experienced. There's huge amount of radiation, contrast. It's highly equipment intensive. We're changing catheters. We're trying to puff contrast here, there, everywhere, doing aortic root angiograms till we finally either give up or find the vessel. And of course, the worst is when a patient with an acute MI presents to you and you can't locate the artery. And it seems that this is an inferior MI, and yet you can't find an RCA while he's having chest pain and occasionally hypertension and arrhythmias. And those are really challenging circumstances. So we're going to discuss this. And by the way, right up front, let me just say, nobody can be an expert at anomalous coronary arteries. But some can be more experienced than others. And that just relates to the number of years that you've spent in invasive and interventional cardiology. Nothing more than that. It's not got to do with expertise any more than anyone else. So the reason I'm giving this talk to you is, firstly, of course, I'd say, Azim, please feel free to come in at any time, and also your experiences are going to matter. It's an interaction, it's an interchange of ideas, it's an interaction and exchange of experiences. And I say that for all the viewers as well, that do bring up points that you may have actually experienced and seen, because it's a learning experience for all. All I can say for myself is that I've been sort of doing PCIs now for the last 37 years. Invasive cardiology and PCIs, and out of that, 25 of those have been in the range of practically very heavy volume operator on an averaging of 1,000 PCIs a year for 25 years. So therefore, you're going to get some vignettes of my experiences around PCI and anomalous coronary arteries. Now, I want to tell you, of the anomalous coronary arteries, we're not going to be discussing any theory around anomalous coronary arteries or the classifications or whatsoever. We're going to discuss practical points of PCI in anomalous coronary arteries. But there's a couple of things which I do need to address right up front. The anomalous coronary arteries which arise from the opposite coronary sinus are the ones which are the toughest to deal with and are obviously the most dangerous. So be it the left main arising from the right coronary sinus, or the right coronary arising from the left coronary sinus. Those are the 2 important ones, and some of those can be malignant. And the reason they can be malignant or have the incidence of causing angina, causing effort-related ischemia, or causing sudden cardiac death is a number of abnormalities in their origin. For example, you can have an interarterial course. By the way, so let me just go back. You have an interarterial course of the right coronary artery arising from the left main, left coronary sinus, which is not so bad, and we'll come to that. But of course, if you've got a left main, which arises from the right coronary sinus and follows the course between the pulmonary artery and the aorta, then of course, that's a malignant course. That could be due to compression. There could also be due to an intramural course as the coronary artery goes through the tissues of the aorta. And that intramural course is a hyperplastic coronary artery with thin vessel wall getting compressed regularly with the pulsations of the aorta itself. You also have the right coronary artery arising from the left side at a very acute angle, and we'll come to that again, which causes a slit-like orifice. And this acute angle takeoff, where it actually bends backwards, causes a slit-like orifice, which again can be associated with ischemia, effort-related arrhythmias, and of course, sudden cardiac death. And then there can be abnormalities within the proximal narrowing, the elliptical vessel shape. There could be ridges within the artery, leading to, again, abnormalities leading to their malignant behaviors. And of course, all this can be then assessed at a stress perfusion or stress imaging, can be assessed at MRI imaging. And of course, patchy scars can actually be seen in some cases over a prolonged period of time, which could be a substrate for lethal arrhythmias. I think we want to understand the important aspects. Now, just because we have to deal with these patients and we are interventional cardiologists, we should also understand the responsibility which lies on us as an anomalous coronary artery is diagnosed. And while there is a lot of different statements around this, one would say, consensus statements around this, I think what I just want to convey to you is that the only one, and that's the summation of it all, the only one which one actually needs to make a decision on for a surgical management is the left main arising from the right coronary sinus following the interarterial course between the pulmonary artery and the aorta. While the right coronary artery arising from the left sinus following the interarterial course can also be malignant and can also lead to arrhythmias and sudden cardiac death. That is a rarity. And that, by the way, falls in between in consensus statements where most people agree that we should not be subjecting them to surgery as prophylaxis. But of course, if they have coronary artery disease and ischemia, we certainly treat it. And if we can treat it with stents, that's fine. And if they require surgery, that's also fine. And people who usually, and I would, therefore say that one does divide it into young people, asymptomatic right coronary artery arising from the left sinus, absolutely no need to do anything. In less than 35 years, one may actually want to do an exercise evaluation, perhaps in all the document ischemia. And of course, if there is ischemia, one may just tell them to actually not do severe exercises, put them on beta blockers, watch them. If they document severe ischemia, one may want to revascularize them. And beyond the age of 35 years, we just rule out other causes of coronary artery disease and keep them under observation. This is for the right coronary artery arising from the left sinus, following an interarterial course. Anything else is absolutely no big deal. Now, we follow this principle in India, and this is the Indian consensus document, which says anomalous coronary artery arising from the opposite sinus on a conventional angiogram as an incidental finding. Look for an interarterial course or intramural course. These are considered as the anatomic indicators of high risk. On the CTA, symptomatic with angiographic significant lesion, more than 70%, or a positive stress MPI. Yes, you can do an angioplasty or bypass surgery. If there's profound ischemia, of course, if there's a lesion, we prefer angioplasty. And of course, if there is no ischemia demonstrated or no lesion in the vessel, it's a medical management. Now we have interarterial course, we have intramural course, RCA with interarterial course, stress myocardial perfusion imaging, which is negative, which is medical management. If it's positive, you can consider a bypass surgery. But of course, if it's left main arising from the right sinus, it's always considered for a surgery.
So Ashok,
Yeah,
Someone's
please,
asking, which I think is a good question. If you
please.
look at that flow chart,
Yeah.
why cabbage and not coronary reimplantation? If you look
Oh,
at the
right.
Indian flow chart.
Okay, I should say absolutely. I should say surgery.
Okay.
Very important question. Yes, I would say surgery, which could be also in many occasions unroofing of the vessel. If it is intramural, it could be reimplantation of the vessel, and certainly not necessarily bypass surgery unless it was clearly ligation of the vessel and a surgery for any other reason. But that's true. So that should not be bypass surgery. If it was a stenosis, then it would be considered as bypass surgery. And I think that's what it actually meant when it said here, a lesion greater than 70%.
Thank you.
Now, this is an important aspect, which I think this is a very nice paper, which was a publication from this year in the JACC cardiovascular intervention. I would urge all to look at this, and many of you may have already read this through. It's a good one because it gives a good perspective of anomalous coronary arteries and the way to intubate these. It goes through a variety of catheters, as you can see here. But I would dwell on some aspects of this in my talk, more so about the right coronary artery arising from the left sinus. And if I point this out to you, there are usually four areas where the right coronary artery would arise, but the one which arises extremely close to the left main and is one of the commonest forms is the toughest to intubate, and you would soon understand why, because it just takes a backward course straight away with a slit-like orifice, and it's very difficult to be coaxial to this or intubate this. The ones which arise anteriorly, the one which arise superiorly, can all be intubated with an Amplatz diagnostic or a guide. However, this one is one which there's no coaxiality and the most difficult to intubate. Of course, a variety of catheters have been described for this A, which is arising next to the left main, and we will also address these issues very shortly. Let me take you, this is a throwback. This is a very interesting throwback from 1992. But it also gives you a flavor of what we've gone through 30 years ago, when there were no stents, when there were very basic antiplatelet therapy in aspirin, pasantin, and dextran, where the surgeons would stand on our back all the time with a theater empty, telling us that we needed to finish the angioplasty so that they could start their cases. And they would allot time for an angioplasty because the theater would have to be standing by. Well, this is a 52-year-old male, class 3 symptoms, exercise test was positive. And he had this anomalous left main arising from the right coronary sinus, as well as an RCA disease. He refused surgery. And in those days, people would think that we're mad if we did balloon angioplasty to this. But you have RCA in the aria projection showing a high-grade stenosis and then a moderate stenosis in the mid segment. You have an anomalous left main arising from this right coronary sinus following not an interarterial course, and therefore following an anterior wall course. It actually has a high-grade stenosis in the circumflex, and then, of course, a long stenosis further down going into the OM2. This patient also has a severe ostial LAD stenosis. Admittedly, the LAD is not the largest of the vessels because RCA was, as well as the circumflex. Well, this guy refused surgery and therefore became a candidate for balloon angioplasty in those days. And here you see, this is a 8F guiding catheter. Those are 8 French guiding catheters in those days. It's an AR1, intubating into that. The best projection, by the way, for anomalous vessel, left main arising from the right sinus, would be an LAO and a cranial projection, as you see in this, where you see the curves quite clearly. And of course, then you have the ariocaudal. So iliocranial and ariocaudal. So balloon angioplasty with a 3.5 balloon, and you see these names, which are fairly weird in the present days. These are the balloons at that time which are used. And balloon angioplasty to the proximal 90% right coronary artery. which was then followed by me doing a circumflex proximal 3 mm balloon dilatation, a long dilatation of a 2.5 going down to the OM2, revascularizing that circumflex, and then a balloon angioplasty to the ostium of that LAD, with a balloon inflated across into the left main, going into the LAD along that right angle, leading to a great revascularization of all those vessels. I would shudder to do that angioplasty, a PCI today, even with stents, but well, I did it in those days because there was nothing better to do, I guess, building up the PTCA program, as we called it. Well, this guy did well, but I sent 6 months later, did his exercise test, it was negative, and I sent this one for publication, and 3 journals refused it, saying, we do not recommend such heroism, which would create bad examples for interventional cardiologists. Well, the patient came back 2 years later with angina, and actually that was related to a new lesion, which is in the distal RCA. Lo and behold, the RCA proximal was great. Balloon angioplasty resulted in great, no restenosis in proximal circumflex. The vessel looked great all the way down to OM2, and lo and behold, the ostial LAD was also doing well. And then, of course, 2 years later, in Journal of Interventional Cardiology, accepted this publication. Can you believe that it was the first ever case report in the literature of balloon angioplasty to anomalous coronary artery of the left main? This was my 3 last sentences of that. This is just a lovely throwback. It just takes you back in time as to what we lived through. That coronary balloon angioplasty can provide excellent relief of symptoms for multiple lesions in anomalous left main following a free wall course. And technological advancements in hardware, can you believe 92 technological advancements I'm talking about, and continuing sharpening of operator skills contribute greatly towards successful PTCA of rare coronary anomalies. Well, 29 years later, this got published in 2005 after the 2-year follow, 1995 after the 2-year follow. But we are still, I would say, sharpening our skills in anomalous coronary arteries. We just talked about this, and I won't therefore go through this apart from, again, re-emphasizing that it's the interarterial course, which is associated with sudden cardiac death and exercise-related death. So I think this is the one which to watch out for all the time. The rest, of course, we used to recognize these in the past based on angiogram alone, the anterior free wall course, which I've just talked to you about, the retro aortic course, as you can actually see here. And this is the interarterial course, goes straight through. But of course, now we have CT coronary angiogram for all anomalies, and it's a mandatory to do a CT coronary angiogram to assess these. Now let's get down to the practical aspects of doing PCI in these patients. And I think that's really the biggest learning we've had over the years. So here's this, and by the way, the anomalous RCA from the left coronary sinus is the commonest anomaly that we deal with in our PCI. And I'm not talking about, double orifice or double barrel left main or separate ostias for LAD and circumflex, or anteriorizing RCA from the right coronary sinus, and so on and so forth. The 3 which I'm going to talk about, and those are the toughest ones. The coronary anomalies, by the way, are practically 1 in 500 PCIs, but no, 1 in 250 PCIs that we would do. And of these, majority of them, 75% of them, are right coronary artery arising from left coronary sinus. And then the remaining are circumflex, and rarities, of course, the left main from the right sinus. So here it is, this one. Now, it's very important to start understanding, and now I think we should go to the next one. Yeah, this is just to tell you that this is what we have to face with. And this is why we can't get these catheters aligned, and therefore PCI becomes difficult. So 0.1% of the coronary angiograms, but clearly 0.2% or 0.2% of our PCIs. Malignant course we've talked about between the aorta and the pulmonary trunk can cause angina, can cause sudden death, but asymptomatic patients clearly are very different. Sudden cardiac death is rare, so for asymptomatic patients, it is not recommended that we subject them to a cardiac surgery. For symptomatic patients, yes, if they have got no coronary artery disease, we have that as an important consideration, cardiac surgery. clearly different to the malignant left vein arising from the right coronary sinus, which even though asymptomatic, should be subjected to cardiac surgery. Now, it arises superiorly close to the left vein, and it takes this sharp turn backwards, creating a slit-like orifice, and it traverses commonly between the aorta and the pulmonary artery and moves posteriorly in the AV groove. And hence, angiography is feasible, and you can actually see feasible, but coaxiality of guide catheters, doing a PCI, getting stents are very frustrating, difficult. So here's my first recommendation to you. Use 6 French guiding catheters. The reason for using 6 French guiding catheters is they can behave more like diagnostic catheters. On occasions, it's easier to get diagnostic catheters into these osteas to take angiograms, but it's very difficult to align guiding catheters to do a PCI. So the one which actually sits right here is difficult because you can see the one which arises, I had already said this to you earlier, but here's the visual. The one which arises very close to the left main is the most difficult to align the guiding catheter to, as I showed you in that image. And that's because it just turns backward. It's a slit-like orifice, and you don't have a space to actually turn the catheter into it. I wrote up this in 2005 in a tutorial in CCI, Understand and Use Your Rights, related to the anomalous right coronary artery. And I still suggest that it's still relevant in our present times because we see so less cases, that it would be very good for you to read this editorial up, because it talks about this, but it talks about cheekily saying that incidentally, there are still some challenges in coronary angioplasty which separate the men from the boys, and angioplasty of anomalous right coronary artery is one of them. I truly don't mean that, but truly, yeah, it does. It does. It's a lot of hard work and a lot of skills and a lot of experience that actually comes into dealing with it, RCAs. So if you want to grow up and succeed, and this is to the fellows, you need to understand and use your rights. Here is the origins of the various RCAs from the left sinus. The ones I said were the most difficult is B. These A, C, and D can be more easily cannulated with the Amplatz catheters. And by the way, in ario projection, do remember that those would point anteriorly, and this is an ario projection, and therefore you can intubate them. Though my favorite way to intubate this is, of course, the inverted Judkins catheter. I'm going to talk about this. So that is what we've already discussed. But let's come to these catheters we're talking about. And some of you probably have these in your labs. Lea catheter, the right anomalous coronary artery from the opposite sinus catheter, which is launcher. And this is what it looks like. And there are some specialty catheters. Now, of the specialty catheters, you have the Lea catheter, which is a modified Amplatz pointing anteriorly at 45 and 90 degrees, as is seen here. It can intubate these anomalous coronary arteries and can get more coaxial. That's understandable. It would point anteriorly. Of course, you have the launcher for the right anomalous coronary artery, again, a similar catheter with an anterior curve and again, pointing anteriorly. I certainly have never used these catheters. I don't even have seen them, and they're not in my lab either. This is what I was talking about. If the anomalous RCA arises above the left main, it can be intubated using an Amplatz catheter. Yes, there is the Sherpa NX balance guide. It's got double curves. It uses to the opposite walls. One curve is here. That's the secondary curve. There's another primary curve this side, and therefore it intubates it. But I'm going to actually show you how these catheters can be created in the lab. I've never needed to use these catheters, and that's the reason I haven't had them. But there's also one more reason. You perhaps do one such anomalous PCI or two such anomalous PCIs in a year. And of course, therefore, on that particular day, the dedicated catheter may not be there. You may not have that catheter. And therefore, what other options do we have? The options are inverted Judkins. I love this, and I've perhaps done more than 20 anomalous RCAs just with this with this methodology, maybe even more than 25 anomalous arteries just by the inverted technique. And that's because if you just take a slightly undersized Judkins, which is 6F, 3 or 3.5, loop it with a 035 wire in the left coronary sinus upwards. While you loop it upwards, inverting it, at the same time, give a clockwise twist to it to make it point more anteriorly. Using a 6F guide, it inverts the catheter and make it point anteriorly, and therefore inverts it in this manner, which is coaxial to the orifice of the anomalous right. An important way to do this, but I would get to the next option, and I would get to the next option of what I do more commonly. And what I do more commonly, in fact, at least once a year, I wouldn't say more commonly, but it's a trick that we all need to know is to how to modify catheters in our lab. We come across all anomalies. We come across not just right coronary artery, but we come across dilated aortas. We can't reach the left main. We have to make catheters do different things in the variety of anomalies that we actually see. So I'm actually going to show you how I, at least once a year or twice a year, modify catheters to fit into these anomalous arteries or into these anatomical variations. So that's what you're going to see now. Now, in the past, we used to have this hair dryer. Perhaps many of you have seen it. Some of you may not have seen it, but these hair dryers were extremely hot hair dryers available at salons. Well, unfortunately, I don't keep hair dryers anymore because they disappear. I need them once a year in the lab and they disappear. And therefore, this is what I do. So I don't know whether you're hearing the sound. Azim, are you hearing the sound?
No, we can't hear the sound.
Okay, then I'm going to relate this. I use what is there is the wire introducer. And I use that as a mandrel, and I make a bend, which is what you see on the table is a Judkins left 7 French Judkins 3.5. And I introduce this wire introducer so that the curve I gave as the secondary curve now fits into the secondary curve of the guide catheter. And then I make a primary curve, which is at right angle anteriorly. And that's what I'm bending this wire introducer. So this would now fit into an anomalous right coronary artery. I believe that that's the shape I should give it. It's pointing anteriorly. And so if it's going to lie in the left coronary sinus, it would be pointing anteriorly. I can do this for a Amplatz. I can do this for a Judkins. Now, this is extremely hot water. This is recent, just boiling water, which has been put into this. And I've now just dipped it to it for 30 seconds. And when you dip it in for 30 seconds, it's fine that's become softer and takes the shape of the wire introducer, which you have actually created to a fresh shape with the primary bend pointing anteriorly, also giving a special curve. And now I've just transferred that into ice cold water. 30. So I'm now even changing the bend forwards, mimicking the angle at which it's got to sit into the left coronary sinus, but has to be shaped anteriorly. So the alignment has changed anteriorly. Okay. And I've cooled this enough. That's what I'm saying. And now I'm going to pull this mandrel off. And you have this is the layer shape. This is an anteriorly pointing curve. It actually is firm. You'll see that it doesn't move. And by the way, this is a layer catheter, or even the double looped. So, and you look at it in the RA projection, it sits pointing anteriorly. Look at it in the LAO projection, it's angulated anteriorly. And it's firm. This is what I'm showing, that it won't soften up as you put it into the blood, and you can't take away the shape.
Wow, Ashok, that's great. I mean, I remember, Antonio teaching me how to shape catheters with a hairdryer. I haven't had to do it for a while, but I like this because you can't find a hairdryer in the cath lab anymore, but the hot water is
right.
great. So,
Yeah.
I mean, with diagnostic
I'll just show you one more.
Sure.
I'll just show you one more. And before that, and then we'll have that comment from you. I just wanted to show, and I'm not going to show you a long video, but I'm just going to show you that you can actually, just a moment. I can show you that you actually get the specialty catheter that I created in the cath lab. But look at what you can do. I'm here, got an Amplats, and I say I haven't got a. I want an Amplats even greater than an Amplats 3. I want an Amplats 5. I want an Amplats 6 because the aortic root is so large. So I can just shape the aortic, I create a curve, which is a huge curve on that mandrel, and then make it point anteriorly even. So this was, say, an anomalous coming out of a very dilated aortic root. And then Amplats 2, I can actually, with the same way, convert that big curve that I give. I create a very big curve to turn that anteriorly. Then I decide to turn it anteriorly. So I can decide anything. And then look what I get. I get a huge loop. And now I've got is like a Amplats 6 and pointing anteriorly. So this technique has the versatility of doing anything and changing the shape of any catheter. Go ahead, Lazim.
No, I mean, it's amazing. Like I said, it's just so simple that I like this. Does it work with guiding catheters?
Yes, this is guiding catheter, which I'm doing, a 7 French guiding catheter. So all this is with 7 French guiding catheters. I prefer to do it with 7 French because it retains its shapes better when in blood. The 6F behaves more like a diagnostic and loses its shapes much earlier.
Okay. And I mean, these look like cordless guiding catheters.
Yes, these are cordless guiding catheters.
Have you tried it with Medtronic guiding catheters by any chance?
Yes, I have. And it does the same. It does the same.
We're going to try this soon because we've been doing a lot of basilicas recently. And we tend to use an oversized AL, so AL2, AL3, but at the tip, we needed to face even more downwards, away from it. So I'm going to try doing this. Thank you.
Do this. Okay.
Wow.
Now, there's also an interesting paper which says that you don't need to do hot and cold, and you just turn it and wait for 30 seconds because these are braided. It'll turn anteriorly. And by the way, I've tried this, and that's from the Taiwan group. I've tried it. It lasts just enough for you to put it in, but loses its shape within exactly 30 seconds of it going into the blood. So if you haven't intubated your anomalous right by that time, you suddenly absolutely lost it. So I think the first technique of hot and cold retains shapes for a very long period of time. In fact, it changes it for good, it appears. Okay, so what other tricks do we have up our sleeve? The wire through diagnostic catheter. Sometimes you can intubate these anomalous arteries by diagnostic, and it's hanging there, but you can't get a guiding in. So if I was to take a guide, I'd take a one size lesser guide than the diagnostic. But if I just can't get a guide in, the first step I would do, even before shaping, is wire through the diagnostic catheter. Well-recognized fact. This is a patient. Let's just go again. I could not engage this, but finally just got a diagnostic close by. I think it was an AL1. Get a slippery wire down it. This is why it really is above, but the orifice points downwards. The uptake is upwards. So I need to come from the bottom up. Nothing else will fit in like this. So it has to be a catheter which can come upwards like this. That's a representation. So I firstly modified a diagnostic catheter, and the diagnostic was engaged. It was easy to modify by what I've actually shown you. And the RCA was engaged. I just created a bigger loop. I just had an Amplats, which would actually just look up. And once I've done that, and it also pointed anteriorly, I actually got it in. And then I put a slippery wire down there. And you can actually see after that, I think I put another BMW on its side, and now I've got two wires sitting there. Once we have two wires sitting there, we're actually done, because the way to actually change guiding cat to a guiding catheter is to leave this loop, which is very important. And let me just show you, to leave this loop, which is on the right side, which will tell you that I then would take this out, leaving this loop. And I thought there was an angiogram, but maybe it's next. And this loop of a catheter is left. I then took a champ tube, because that was getting as close as possible. I actually then modified the champ tube to give this right angle curve and a bigger curve. This is the original champ. This is the champ, modified champ. And you can see that my curve is bigger. It points anteriorly. And this is the champ curve. It is a curve that I have in my lab for saphenous vein grafts, and also for really high uptakes of many of these anomalous coronary arteries. And here I actually show you that I leave this loop. I'm taking the diagnostic out. I have left a loop of the wire here, like this, the two wires. And now over the two wires, I get my champ guiding. The first part of it has been helped by an 035 wire, which comes up to the aorta. And then the remaining part is getting this champ or a modified guiding over this loop and inverting over till it actually fits into the ostia. So this loop is very important in the aorta. And now it fits in fine coaxially. And after that, of course, it's a home run coaxial fitting. One just then puts in a stent, dilates vessel, puts in a stent. Of course, got a good result on that. So that's the first trick that I actually do. Reshaping guide, I've already told you about this and demonstrated it. Here's an anomalous right. You can see this runs in an interarterial course. The way you recognize also an interarterial course is by the fact that it's a slit-like orifice and that you have this haziness in the proximal segment where it gets slit-like, compressed, and maybe even intramural out here. You, of course, have a high-grade stenosis further down. So it's intubated with a Judkins diagnostic catheter. This is a non-modified Judkins, just inverted, and with a clockwise twist to point anteriorly. Once that's done, an all-star guide wire is passed down. Again, the diagnostic is removed, creating a loop in the aorta for the guide catheter to come through. Here's the diagnostic is exchanged with a guide catheter. Let's see, the guide catheter comes through, yes. And here it is, the guide catheter now fits in. You can see that simultaneous injection in the pulmonary artery and the aorta show that it is an interarterial, maybe an intramural course. The distal lesion is stented. We have coaxiality, we have support, we have an all-star wire, and then the proximal part of this is also stented, the one which was perhaps interarterial, where there was a compression right up to the ostia. And you now see the final result. There's absolutely no compression, no haziness in that. There was an IVUS done at that time on this. Of course, this is going back 10 years. There was an IVUS great pictures, which I've lost, but at least I can show you the angiographic pictures, which actually showed the slit-like orifice, and then it was gone. This is an interesting case of an absorb extend 2011. Again, anomalous RCA proximal lesion. This is the most difficult to get into, but I actually did manipulate this catheter, guiding catheter at that time. I can't remember, but actually got it better aligned. This is an all-star wire here, got it better aligned, and was able to stent this lesion with a BVS absorb 3.5 into 18, I think at that time, part of the absorb extend, and had a great result. And you can see that I've intubated it with an all-star wire. Perhaps I had modified it at that time. Anyway, 7 years later, this guy comes with a STEMI. And lo and behold, it wasn't the absorb. The absorb segment's looking good. But what can you do when you have anomalous rights and you're in the middle of trying to get this guy who has ST segment, hardly any flow down, to me, one flow down the vessel? And again, I couldn't by the heck of me understand how to get down this. I'm here trying everything. The guiding catheter won't do. The diagnostic won't even invert and come anywhere close by. The Amplus won't. And here, while this patient's having an infarct, I'm modifying a guiding catheter to exactly the same which I showed you. It took me no more than a minute and a half to modify the catheter into something which would fit in straight away. And in that, I was able to pass get a better support, still not cross the lesion, therefore got a guide liner down. And as you can see, get the guide liner, which is my third trick, get the guide liner down, a guide extension catheter, I would say, down, balloon anchoring, a guide extension catheter down into the vessel. And after that, of course, open that vessel up, stent that lesion, do an OCT analysis of that lesion, stent implantation, as well as the proximal segment, which had an absorb 7 years ago. And lo and behold, we had a great expansion. But look at this, great images of no stent in the segment, which had an absorbed clean vessel, no blocks either, golden tube, as one would say 7 years later in the proximal segment. So here's my algorithm for anomalous right arising from the left coronary sinus. If it's close to the left main, I would invert the JL catheter first. If it's not close to the left main, if it's anterior or above, I would just use an AL. If that fails, I have to wire the vessel through a diagnostic catheter, and I would do that if my diagnostic could actually get in, and I could intubate it with a diagnostic. But if I can't, I don't have specialty guides, though I would suggest that if you do have specialty guides, you could use them. But I modify the guides in no more than 2 minutes and succeed with that. But if I fail, then I would modify my diagnostic catheter, get in, track a wire through, and then over the vessel wire, get my modified guide in and complete the PCI procedure. So this is my algorithm for anomalous left main. A brief about anomalous circumflex. I know I'm going on, Azim, what can I do? I just have to have a few things to say, but I hope you'll excuse me for these interesting observations. Anomalous circumflex arising from the right sinus they always follow a retroaortic course, by the way. They can arise from the right coronary artery. They can arise as a double barrel from very early RCA, or they would be totally separate somewhere in the right coronary sinus, but they will go retroaortic. But the worst time is when they have an MI, and you know it's an inferolateral MI, and you know that you just looked at the RCA, there's nothing there because your guide intubates, your diagnostic intubates the RCA, and these arise very early for you not to be able to see a stump even. But the only telltale sign, therefore, is that you don't see a circumflex. And that can also happen if the circumflex has a second orifice, has a separate orifice from the left coronary sinus. But then you have to take aortic root shots towards the left main, seeing whether there's a separate circumflex, and then aortic root shots towards the RCA in an LO cranial projection to see whether you see a stump of that anomalous circumflex. So remember, if there's a blank area in the circumflex on the left coronary artery shot, and you got an inferior or inferolateral MI, your right is okay. Start looking for an anomalous circumflex by the very methods that I've actually told you. So here's a circumflex which arises totally separately from the right sinus. This is an interesting case, 46-year-old lady who had angina. She had 2 lesions, and the lesions are, of course, that there's a high-grade lesion in the right coronary artery, and there's also a lesion in an anomalous circumflex, which arises from the extreme proximal 2 to 3 millimeters from the right coronary artery origin. Now, if I had this slightly in, you can imagine I could have missed this anomalous right coronary artery. So, of course, seems no big deal. The best, by the way, guiding catheters to use for anomalous circumflexes are the right coronary artery, torqued slightly more, therefore clockwise torque slightly more than what you would to get into the RCA. So it will look backwards and it'll find the origin, which is usually behind the circumflex because it tends to go posteriorly. So you take it out, but I'll just come to that. But the best way is to keep, if it's too early on, the circumflex arises too much proximal, then put a wire down the RCA so that your guide doesn't come out, and then keep talking it slightly more clockwise so that it's getting more and more posterior by puffs, and you would come to the circumflex. So leave a wire down the RCA. And then, of course, once you find that circumflex, you then just put a second wire down that circumflex. Now you've got 2 wires sitting, one in the RCA, one in the circumflex. That's the best stability you can, and then you can continue to work on the circumflex. But anyway, coming back to this case, I dilate it, no big deal. I stent it, and there it is. And again, it looks good. And then I go back in and do my post dilatation. And again, it looks not bad at all. And I therefore remove this wire. And after I remove this wire, this vessel closes up. I have dissected the ostium without realizing it. And the wire had propped up that dissection. And as soon as I withdrew the wire, the ST segments went up, the patient started complaining of chest pain, started having hypertension. Now, I haven't recorded that injection, which is on the right side, that the vessel closed up and I gave a puff and it was no more there. And there I then started, it was an ostial dissection with a closure. And then I had to, this is how you actually do it. You can see that I have dye staining in the aorta. Whenever there's an ostial dissection and occlusion, you actually have to surf the ostia, remove the guiding catheter completely, because your guiding catheter would be in the dissected plane, always finding the dissected plane and not the true path. From there on, here's a guiding catheter, which is 6F, or is it a diagnostic, 5F diagnostic? And I'm surfing through a very soft wire. I think in this case was high torque floppy at that time. And I'm trying to locate for a new path. And I finally do find a new path with a diagnostic sitting out. This is the new path because it actually goes through fine. And this new path, therefore, gets me down. I then actually have docked it. The diagnostic gets removed and changed to a JR guiding catheter. And for the JR guiding catheter, don't leave a loop here. You leave a curve here. And you get it with an 035 wire, as I've told you earlier. The guiding catheter comes in. And when it comes in here, you have a loop here, not a loop, but a curve here. Clockwise twist on the curve and pull it through. And here you will see that here I'm clockwising it. I've got a redundant curve out there. And this guiding then just comes over. I then, of course, have to stent the ostia. But then when I stent the ostia, remember there's an anomalous circumflex to deal with. And now I've actually lost the circumflex because the dissection is into the anomalous circumflex. You can see that the dissection, the anomalous circumflex is nicely dissected. And there's a hematoma down that circumflex. You can only see a bit of it filling up in the proximal segment. Having done that, I find my path into the circumflex by clockwise twisting it slightly. And then being faced towards the circumflex, I find my path through a soft wire into the circumflex. And then I do a tap into this anomalous circumflex. And this is in the iliocranial projection, by the way. That's where you see the bifurcation or the origin of an anomalous circumflex, the best iliocranial projection. I've done a tap, I've done a kissing. I finally have a good result. And I finally have finished this case with a final pot, I think, or whatever I could call a pot, but at least doing an optimization to the ostia. Check the left main because you can sometimes have hematomas spreading across into the left main, causing stenosis or occlusion of the left main. If you have aortic root hematomas, that left main look fine. And I therefore have a good result on this, on this bifurcation. I think I'm going to actually stop here. Okay, just let me show you the final results. I think it's always worth seeing the final result once you have such an issue with what it is, and that yes, both those vessels are flowing and stented. And finally, of course, I got the patient's pressures up. I managed that with inotropes at that time. I said there's no time to put in intra-aortic balloon pumps. The time was to salvage the vessels rather than put intra-aortic balloon pumps, and I salvaged the vessels happily. And the patient did fine thereafter. So I think I'd stop here and say, well, yeah, these anomalous left mains, we keep learning. We're still learning how to get over them. But of course, the more PCIs and more angiograms we do, we'll face them and we'll get out of them. And we'll actually have another case, another story to tell at another session. Thank you very much for your attention. Thank you, Azim. Again, I apologize for going over time.
No, Ashok, you're not over time at all. Can you go back just one or two slides? I wanted you to show everybody again. Just go back. Because this applies even to native right coronaries. You just did it so brilliantly when you showed how you manipulated the catheter back into the ostium.
Okay.
If you're going to show that one more, I just think for the junior operators, this is something that they really struggle with.
That's right.
And this happens also when you're doing a difficult right?
Correct.
And the guiding catheter comes out, you got too much slack. It's the same technique. So if you could just say that again, please. Go through
So,
that
so
again.
here it is. Now this is a diagnostic. And again, we're just going to go through the technique of how you get a guide over a wire. So here it is, the wire in the, and it's better to actually have a support wire down, because that is the best way to do it. So BMWs can do fine, but if we All-Star or have two wires. Now what you have on the right side, of course, is a guiding catheter coming. It's an 035 wire also, along with that 014 wire, which is down the artery. That's always very good, because you don't want to support the 01, you guide to just be supported in an 014 wire. It's also better advantageous to get a 6F guide, because it's got less of a ability to sort of pull your wire out, because it's less rigid. So the 035 wire has to come close and down the ascending aorta, so that you can get your guide to just above the ostia of the RCA. Now there, you then remove your 035 wire, and now you're just sitting alone on the 014 wire. But what I hope you can see, that curve, which is a redundant curve, it actually comes like this. Because if you don't have the redundant curve, your guide is going to be facing the opposite side till you clockwise turn it towards the right coronary ostia, and again is going to pull everything out. So that redundant curve, the next step is two things. You just can't get it in just by clockwise torquing it. As you clockwise torque it, you also have to take away that redundant slack at the same time. There are two actions in one, otherwise it won't happen. So here's the torque happening. At the same time, the redundant slack is taken out and the guiding catheter goes in. If you do one or the other, you will pull the wire out, and that's what's going to happen. So it's got to be two things at the same time.
Right. That's great. This is just such a good technique, and it's I think one of the hardest things for fellows to learn when they're doing, with right coronary arteries. This, when you lose your guide and it comes back, how to manipulate it to get it back. And this is a beautiful example, Ashok. Thank you. Everybody's asking, and I'm sure you do what I do. I use this technique a lot of putting a wire down and then exchanging from a diagnostic to a guide. I like you, I try and do two wires. I am assuming you're using 300 centimeter wires, correct?
Yes. Okay. But if I no, I don't. We have the ability to extend this, because I have the guide, sorry, the wire extensions.
Okay.
So I actually extend them all, the wire extension.
Okay.
See, we're using monorails all the time. So these are problems when you actually face them. We don't keep 300 centimeter wires with us. So we just dock them and extend them.
Okay, so you put a dock on it. And I think the other great technique here you showed, which is very useful, is to have a third wire, which is a 035 wire, in the aorta, just to help you get the guide out and not lose the slack. That's a really great trick. Okay, fantastic. So I've got the fellows on. I'm going to pass it on to the fellows, Ashok. I'm sure they've got questions.
They ask the toughest questions.
Watch out. Here we go.
Watch out.
Okay. Go ahead. I see Andrea.
Yes, thank you for this great lecture. I wanted to ask you about the algorithm that you showed at the beginning. What do you think if...
Okay, which okay.
No, I just wanted to ask you if there is a role, or in that case, what is your opinion regarding invasive measurements such as FR, IFR, or for the CT assessment, angio-CT assessment for interarterial or intramural courses?
Right, that's a great question. So there's certainly a role for a lot of assessments, but a lot of assessments can be done non-invasively. But IVUS, by the way, looking at the slit-like orifice, looking at the compression via IVUS has a major role. FFRs and IFRs haven't been recommended or tested out in these circumstances, because relied on CT, exercise nuclear scans, and IVUS as a 2B. By the way, the rest are a 1A. IVUS as a 2B for anatomical abnormalities. For functional assessment, it is clearly at the moment nuclear scans, because these are non-invasive assessments as opposed to invasive assessments. So that's what I would say. Now, if you were assessing a lesion in one of these arteries, then it would be reasonable to actually do an FFR. But the data for FFR for prognosticating these patients to decide in asymptomatic patients for proceeding to surgery does not exist. I hope you understood. There are two aspects. There's those ones who are asymptomatic, who you want to therefore assess through nuclear scans, those who are symptomatic but don't have disease processes and therefore normal arteries or normal looking arteries, and then those with coronary artery disease. The coronary artery disease may have some role for FFRs, the others don't.
And about angio-CT, what do you think?
Well, angio-CT has a huge role. CT coronary angiography is one of the clear indicators of assessing anomalous coronary arteries. In fact, that has class 1A. By the way, MRIs have a class 1B indication now, and you have a combined assessment of these by doing, say, stress MRIs, which have, getting more and more investigated in these patients.
Thank you.
Good. Thank you. Samina, Bob?
Thank you, Dr. Ashok, for such a great talk. I'm still rewatching your calcified PCI talk. And then this one, I have a question about the sizing of these anomalous coronaries. Sometimes, angulation and sizing, they look indeed anomalous, as the name say. They don't seem to be the classic anatomical compared to RCA, left main LED, and almost look like grafts in some cases. What is your experience with, sizing, stent size, pre and post dilating these lesions? Because what sizes do they usually come in? I ask this question because if you're a new attending faced with an acute coronary syndrome in the middle of the night, you may be, after finally engaging this coronary, you may now be faced with some sizing issues. Thank you.
Yeah, I think once you've intubated them, and if you've really got good intubation, then you can get your imaging catheters down. That's very clear. And IVUS imaging is easy in these because, as you know, once you've intubated them and you've got a wire and you've got what is a support wire, it's either a BMW or even a BHW, you can get imaging done. And therefore, I would certainly recommend that in most of these, because you don't want to come back into this, you want an optimal result, you want to have least restenosis, and you don't want to have stent thrombosis because these are not pleasant to chase and get back into. Certainly recommend imaging and sizing and optimizing based on imaging. Obviously, IVUS is easier to do because you don't have to be so co-aligned to the ostia. OCTs are difficult. You have to have total alignment to get good contrast injections. And therefore, 7 times out of 10, if I have to image them, I would be doing an IVUS.
Thank you.
Andrea, there was another question that you'd asked, but I would also tell you that much of the anatomical, there are anatomical predictors of a high-risk patient, and that goes very importantly both for right coronary artery, which has an interarterial course when it arises from the left sinus, and those are very important, and that is also judged, by the way, on the CT. So CT coronary angiogram will predict for you also the way it arises at an acute angle. It also shows you the ostias at an angulation. It predicts the intramural course, which is the first few centimeters, first couple of centimeters or a centimeter of the anomalous RCA where it runs in the wall of the aorta. And therefore, those are the predictors of high risk. And that's the other reason why CT. So it's not just for its course, which is one of the very important aspects, but also for the high-risk predictors, the anatomical high-risk predictors.
Thank you so much for a great talk. It was very, very educational for me. I learned a lot. One of the questions that came to my mind was when you were planning for stage PCI for these patients, like, someone has anomalous coronary and one of the tough ones, and you're planning for a stage PCI, is there any benefit from radial versus femoral approach in your experience?
So that's a very, very good question. I am a femoralist more than radialist, okay? Though I do radials, I do less interventions radially than femorally. But you're right, femoral, but for anomalous coronary arteries, depending upon the variations and depending upon the changing of guides and the number of guide catheters one may need to use, modify, adjust, the same goes for diagnostic. Femorals are preferred, though, by the way, there are some publications related to using radials and how anomalous right coronary artery, which arose close to the left main, can be done more easily through radial than with femoral. Okay. Now, whether that is really true, because that's a couple of publications related to that, I can't comment to that because I would never chase an anomalous right through a radial. I would always do it femorally, as you watch me do. But that's the only anomaly which is said to actually be easier through the radial in every publication, but majority of the cases, by the way, majority of the publications, case reports, etc., have all relied on femorals rather than radials. So you're talking about 90%, 95% of the publications actually being femoral approach to anomalous coronary arteries.
And my second question is that, like, in those scenarios that you have the RCA coming off really close to the left main, in your experience, is there, like, when you were showing us, I was thinking like there might be a risk of damaging left main ostium and causing dissection and injury to the left main when you're trying to engage the RCA. And have you ever faced a scenario like that? And how would you troubleshoot if that happened?
So yeah, I should have emphasized one important fact, that whenever locating or even intubating the anomalous guide manipulations, at least at the ostia, have to be minimum, because these ostias are abnormally located, and actually dissecting these ostias is far more easier than anywhere else, primarily because you're always malaligned to them. So that's the first point. And you know yourself that the safest way to actually intubate any orifice is to be aligned to the orifice, even if it's a native right or even if it's a left main. So that's the first point. But you're right, you've got to be careful. And that is why I think it's always good to get an idea how your diagnostic functions in getting to these, the anomalous artery. So even if I was faced with an anomalous artery, and say if I was referred an anomalous artery from another center and said that the operator couldn't get through, and he said, you try to get through, I would actually first go in and use a diagnostic to see what diagnostic gets me closest to it. So does my amplats bend in a manner that it's, is it getting anywhere close to the ostia? Is it actually, can I talk my amplats AL2, or is it AL1, which would get me closer to it? Can I give a clockwise turn to it? Can I even get my diagnostic JL3.5 inverted to point towards it? Now that way you know that you're least traumatic to the ostias because you're using a diagnostic catheter. From there on, you then convert to a guiding catheter. So if it's a 3.5 which got me closest to the ostia of the anomalous right, I would then take a 3 and do that manipulation. The second thing I always mentioned to you was I use 6F guides because they are softer than the 7 French guides. Only when I actually modify guides would I use 7 French, because the modified guides retain the shape better as 7 French. But if I was using an unmodified guide and I had to loop it, or I had to turn it, or I had to twist it, it'd be 6 French. So yes, you have to be cautious, but dissection, if you're cautious, is not usual. It's a rarity because you take these steps in making sure that you're preventing dissections of these anomalous arteries. And finally, you saw that once you're actually putting it over a wire, which is into the coronary artery, then you automatically, being very gentle, you either modified your guiding catheter or making sure you've got a support wire, which helps you to get your vessel into the ostia. Finally, don't forget the use of guide extension catheters. Absolute neat trick. You may be sitting out, you don't have to try and shove your guiding catheter in, just bring your guide extension out and let it sit in the proximal vessel. You'll be co-aligned, you would be least traumatic, and you'd be able to do every intervention and evaluation and imaging after that.
Thank you.
Right. Thanks, Samina. Jesse and Nikos?
So my question is similar to Andrea's question about the physiologic assessment of these lesions. So if you have like an equivocal like CT about or CT FFR, and then you want to do invasive assessment, I think that one of the problems with these lesions is that they are dynamic. They're not like the fixed calcified lesion. So how would you normalize for that? I think the FFR is probably not going to be, or the RFR probably may not even be positive, but it may be significant.
So should I say that I don't think anybody knows the answer to that question, because there has been very little related to measuring these indices in anomalous arteries without any lesions, which actually have no atherosclerotic disease. I have at least not found publications directly related to that. Angelini is the one who's done a lot of work around imaging these arteries. And I know that there's publications on flow measurements, but I can't recollect what the assumption was. And certainly it doesn't figure out in any of the recommendations for evaluation of ischemia.
Thank you.
But there's a lot, the physiology has been measured down these arteries by Angelini, and great intravascular ultrasound images, as well as physiological measurements have happened very recently. And he's done the most work on this.
Thank you.
So that's the last question.
So do look up Angelini's publications on this.
I will. Thank you so much.
Thanks, Dr. Seth. It's always great having you, and I'm always inspired by the creativity and the fun that you have in the cath lab, and it really like makes me want to bring that energy to my approach. So thank you for that.
Thank you.
So one comment, I think you really do have to be thinking about femoral and radial access, especially if you're doing right radial diagnostics. I did have one case, again, very limited experience, where we were actually trying to ensnare a part of an entrapped balloon out of the left main, and we had been doing femoral the whole case, but couldn't get any catheters that could grab it or snare the balloon, and ended up switching to a radial. And then the angulation for approach totally changed, and we were able to snare it pretty easily. So I think it, like you said, it's not really published a lot in case reports, but if you're really struggling, you really want to make the diagnostic, it's always interesting to think about changing access as well as changing catheters. The real question I had for you is, we've all had those cases where we use a, let's say an AL 0.75 or some type of diagnostic catheter, and then we go in for the intervention with the exact same shape guide catheter, and it doesn't work and it doesn't fit. So I can imagine that would be a nightmare for anomalous coronary. Are there cases, I know you're talking about safety and damage to the ostia when you're trying to engage, but are there cases where you just go up front with a guide, especially if you're thinking that you're going to be, doing some type of intervention? And if so, what French do you go with? Do you go with 6 French up front? Do you want to switch to a 7 French up front?
So firstly, on your comment about switching to radial and keeping that in mind, I couldn't agree with you more. I think you're absolutely right. We can't be stuck to one approach. We got to think 3-dimensionally. First, I always say, start imagining these anomalies 3-dimensionally in your mind. After you've sort of poked around, or after you've surfed around and are getting close to it or not getting close to it, you must look at it in 2 dimensions and start making it 3-dimensional in your mind. You can't keep doing the same thing again and again. Therefore, that's also correct. And if now, when I do that and I'm not getting where I am, that I've just showed you that I try to modify catheters. So that's why I'm able to get into many of those where I'm actually modifying catheters. But if you weren't, you're absolutely right. The other approaches could have a different direction to those to those anomalies. For example, while in those case reports of anomalies, many radialists change to femoral. There's also the fact, I've forgotten the name of the catheter, but it's the catheter which intubated it very neatly from a radial. And I'm talking about the right coronary artery from the anomalous, and this was mentioned by at least in 2 case reports, was this French name of a catheter.
Not the Ikari, right?
Huh? Not Ikari. Ikari was mentioned in one, but it starts with a B. What's this French name with a B? Was it a Barbeau catheter? No, it wasn't, but it's Brageron or something like that. But radialists would know it better, but that guiding catheter seemed to be mentioned by 2 or 3 radialists as an approach to RC. So that's another interesting aspect for you to look up and see, so that you can keep in mind and perhaps remember that. So I agree with you. The second aspect of what you said was about what was the second?
It was the challenges when you switch from a same shape diagnostic catheter to a same shape guide catheter.
Yeah, so you'll always have that challenge. Remember, it's 6 French, I said, because they are closer to 5 French than the 7 French in terms of their mobility, in terms of their flexibility, in terms of their softness, and in terms of how you can actually rotate and curve them. So that's the first aspect. The second aspect is, but the guiding catheter you choose should always be one size less than the diagnostic catheters. And that's very well recognized fact, because again, of the same fact that because they're rigid, the curves are slightly bigger, you actually therefore are easier and closer when you do these things. If you take a size smaller, and that's what I've done all my life, and I've been okay with that approach rather than the same. So do that as well. And of course, finally, you said, do I ever go in with a guide catheter directly in Anomalous? No, you've practically either, if you haven't done the diagnostic and it's referred, it's always nicer to do the diagnostic and start understanding it 3-dimensionally before you take your guiding catheter in. It's safer and it gets you success faster. It actually less change of guiding catheters, and it's also less contrast, and also less time, and perhaps less trauma. So you're actually advantageous to at least know how the diagnostic behaves.
Thank you. Ashok, as expected, there was a phenomenal session, and we all learned so much, as always. I can't thank you enough. Have a great day. I look forward to seeing you in person soon. And we're going to ask you to do more lectures with us, because you always give such practical advice from all your years of experience that the fellows love hearing. I learned from you as well too. Thank you, Ashok.
Thank you. And I love the fellows. I mean, they're all thinking so much. They ask me questions where I wish I was with them in the lab, sussing all these things out. So great guys. Keep doing well.
Come cath with us.
Would do.